And sort of, today's agenda is really to hear about what's going on in Massachusetts in terms of payment reform and lots of other innovation going on. David Salmon and I are always saying we have Massachusetts envy at times, sort of all the hubbub that goes on there. We're just a sleepy state with nothing happening in the health system. And
I don't believe that.
of course not. But and David is going to, again, take us through some of the things that are going on and some of the innovative ideas that they're working on. He, despite looking young, has lots of experience. And but David sort of worked in the legislature, first as a staffer at the Ways and Means Committee in Massachusetts, and then working with the President of the Senate, Therese Murray, and was there when a lot of the legislation that has happened, that he'll take us through a timeline of when a lot of the legislation was going through. And so he not only was there when it was created, but now he's in a position where he actually headed this health policy commission that is trying to shepherd it along and shape it. And again, I won't steal your thunder, but we're really pleased to have him here and share something. You come with great reputation. People in Massachusetts all super impressive.
Well, thank you, and thank you for having me here today. Thank you, Jim, and for David for setting this up. This has been a real treat to come down here. I took the train down this morning. I'm going to be taking the train back to Boston this afternoon. A lot of work to be done here, but really appreciate the opportunity to meet with you and to share some of the things that we're working on in Massachusetts and have a conversation. I think the format here is really an informal one, and so while I have some slides, I'll try to run through them probably at a really high level and pretty quickly. And then really just open it up for a conversation. One of my first hires at my new organization was a McKinsey alum, and so we do a lot of PowerPoints at our new organization. But I think to address the elephant in the room, yes, I am a young person, but I have been working in healthcare policy for over 10 years now. Worked for the state of Massachusetts for over 10 years. I know because 10 years is when you're eligible for a state pension, and I hit that mark, and so now I can retire and have health care for the rest of my life is one of the great benefits of vesting in Massachusetts. So that is a pretty good deal.
Well, we'll see if it's still there.
Yeah. I have a vested interest now, as they say. So I, happened to be really at the right place at the right time when I started my career. Worked for the state budget office, or the legislative budget office, working on the Medicaid program. And at the time, we had something called the uncompensated care pool, which was this $500 million behemoth of a fund that was going to pay for uninsured care in Massachusetts. And 3 years later, was lucky to be there at the time when Massachusetts decided to really take a step forward in healthcare policy and to tackle something that had not been tackled by any state before, which was the healthcare access piece. I think one of the unique things about Massachusetts and healthcare policy has been the way that we have tried to work to address some of these really challenging issues and not let them kind of daunt us from taking some experiments along the way. In 2006, it really was a coalition of providers and health plans, consumers, labor unions, Democrats, and of course our Republican governor at the time, Mitt Romney, who came together to say, let's chart a new path for Massachusetts about how to make healthcare accessible to everyone in the Commonwealth. And we didn't know at the time whether it was going to succeed or not. It has. Now Massachusetts, as you all know, has the lowest rate of uninsurance of any state in the United States. But I think one of the common misconceptions at the time was that we really just ignored healthcare costs when we were debating that bill. And while it's fair to say that there are not a number of provisions or targets within that first bill around healthcare costs, the political leadership at the time was very aware that in order to make this promise something that was going to last for a generation, that healthcare costs was going to have to be the next challenge that the political leadership would need to face. And actually bringing the entire industry into that commitment really led to a place where we could really start to have some harder conversations about how we do tackle healthcare costs without everyone standing in the corner and playing defense. And so after Chapter 58, we passed a number of laws, kind of incremental steps to address healthcare cost containment. First, really kind of focused on transparency. How do we understand what the healthcare cost drivers are in Massachusetts? How can we make prices transparent for the first time and the relative price differences that exist between some of our big institutions in Massachusetts? We passed a law in 2010, kind of at the height of the recession, really focused on small business reform, promoting new types of health insurance products like tiered and limited network products, which are some of the fastest growing products that we have in Massachusetts now. But I think there was an agreement throughout this time that, and the economy really focused our attention on this, that healthcare cost containment was really an economic competitiveness issue for Massachusetts. It was something that we saw that was growing at an unsustainable rate, and in so doing was pushing out growth in all other sectors of our economy. And that was something that I think everyone can see most dramatically in the state budget and kind of municipal budgets, when you see that healthcare costs in Massachusetts grew 60% in a decade. Every other area of investment, education, transportation, public health, decreased 20, 30, 40% during that same decade. So this is pressing out all of those priorities. But what we saw was also this is happening at a business level, and a small business level, and pushing out the ability to make new hires, pushing out the ability to do wage increases. So the politics of this were really an economic politics. This was about how do we make Massachusetts competitive in the long term, and really being able to create an environment where jobs could grow in all sectors, not just in the healthcare sector. And so came together again to pass another comprehensive law in 2012, which we affectionately call Chapter 224. We have these little nicknames for all of our laws, and really was kind of the next phase in healthcare reform in Massachusetts. I think the most, and here is just the picture of our current governor, Deval Patrick, signing that historic law. I think the most interesting piece about this particular law was the health benchmark. We set ourselves a goal. We understood that healthcare cost growth was something that was desirable for kind of a well-functioning economy, but was more about keeping that rate at a more sustainable level. And so thinking about how it had been pushing out and how a greater proportion of our economy over time was going to healthcare, the benchmark and goal that we set for ourselves in Chapter 224 was to bring that cost growth down to the growth in the overall state's economy. And so that would require a reduction in growth of 3 to 4% off of the historic trends, but would still allow for growth. This wasn't kind of cutting into zero or cutting into the negative. And there was a lot of political debate at the time about where you set this number. Do you let it grow a little bit faster? Do you let it grow a little bit slower? There's all this waste in the system. Can we pull that out faster? And ultimately it was just, let's just pick a number. Let's pick a number that we can rally around and have that be the goal. And the goal here was this economic goal. It does change over time. After 5 years, it does allow for slightly negative growth, kind of beyond that economic growth platform. And then in out years, the commission where I work now has the ability to modify based on experience. But that's kind of a long ways out. We are still kind of in the first year of measuring against the benchmark. The benchmark is 3.6% for growth between 2012 and 2013, and again 3.6% for the year after. And so we've kept that level pretty stable at 3.6% as the target we're trying to get to. One important, yeah?
Did you adjust for population changes? Is that per capita or?
It's per capita, yep. One interesting thing about what we're measuring here as far as growth is the per capita sum of total healthcare expenditures. And so different than other types of benchmarks that might only be focused on a Medicaid program or only focused on the Medicare program, this really is commercial, Medicare, and Medicaid all together. And the net cost of private health insurance, and so consumer out-of-pocket spending. So the idea was really to make something that's as broad as possible, because we really wanted to avoid what has happened so many different times in healthcare, is where you push down in one area and it comes back up in another area. And so if we were only going to push down on our Medicaid program, what would that mean to our commercial market? If we were only going to push down on our commercial market, what would that mean to consumers who may see higher deductibles or higher out-of-pocket spending as a result? So we really see this as something that's a comprehensive measure across the board. The net cost of private health insurance was reflective of the fact that we have some providers and health plans that are now partners together. And one could have imagined a scenario where the provider would shift some of those care coordination efforts to the health plan. And so really wanted it to be as comprehensive as possible.
How about self-insured large employers?
Included.
They're included.
Yep. And I think the other thing about this is it's an all-in benchmark. And so we do allow for ability for some areas to grow faster than the benchmark and for other areas to grow more slowly. It's not a cap that exists on rates across the board, but really kind of a measure that's supposed to capture all things. So there may be areas in the Commonwealth in Massachusetts where we say we have underinvested for a long time in primary care, behavioral health, mental health. Maybe those deserve to grow at a faster pace, but there are other areas where there are efficiencies to be had. So that's the central focusing part of this law. And then underneath that, it has a bunch of strategies about how the healthcare system is to achieve and to help get be successful in reaching that goal. And really, our law is a market-focused law. It really allows the market to pursue some of the strategies that it had already been doing, but also understands that government is going to play a role in making sure, holding the industry accountable towards meeting these goals, as well as monitoring and helping to guide the transformation over time. So the goals are pretty widespread here, and the key strategies, it's the four big ones that you hear about in all things when it comes to healthcare policy: transforming the way we deliver care, reforming the way we pay for it, creating a real value-based healthcare marketplace, and engaging purchasers, and by purchasers we mean consumers and businesses, in making value-based decisions about their healthcare. The law set up two new state agencies to help implement some of the key initiatives within this law. One is the Center for Health Information and Analysis, unfortunate acronym of CHIA. And CHIA is really a data analytics hub. And I think there was a real recognition that to be able to do this right, to be able to do this well, you need really good, sound data. And so set up, kind of reformed an existing state agency and set it a little independent from the administration, and felt that this should not be an area where politics are going to drive what the data tells us, but really let the information drive that. They collect and maintain our all-payer claims database, which is a really powerful tool for us to be able to understand trends in the healthcare marketplace, and really support us. Where I work is the Health Policy Commission, and so a separate organization that really is focused on the policy end of this. Again, we have some independence from the administration. I report to a board, so I'm the executive director, I report to a board. The board is appointed of members who have particular expertise in different areas of healthcare policy, labor representative, hospital, health plan, behavioral health. Importantly, they can have no financial ties to the industry itself, and so this was not something where the board was set up to have the president of this association and the president of this association, the president of this association, but really to have some experts at the table. And again, appointed from the governor, the attorney general, and the auditor, with no one of those individuals having a majority of the board. Here again, to really create some independence so that it's not tied to kind of one elected official, but can create some long-term policy over time, not wanting a change in administration to really dramatically change the direction of where we go. I'll mention really quickly, the chair of our board is Dr. Stuart Altman, who is a longtime healthcare policy economist. He started his career for the Nixon administration and has been working on healthcare cost containment for the last 40 years. And so we make a pretty good duo, the two of us together working on these things. Going to run really quickly through some of the different things that we're doing at the Health Policy Commission as far as our policy agenda, and really I'm going to keep this as brief and as high level as possible, understanding we can get to some of these details in the conversation. So here are the four big things that we do. One is we're promoting that transformation in care through a certification program of patient-centered medical homes, and also accountable care organizations. Secondly, we're making some strategic investments in community hospitals in order to support the delivery of efficient care in our communities. Third is we're monitoring the system and monitoring cost trends and trying to understand those areas where the pressures may lead us to believe that we're going to exceed the benchmark, where there are opportunities for new policies to be able to get cost savings out of the system, where some of their barriers right now that's preventing the market from being able to achieve those savings. And then finally, kind of a new function for state government here, an ability for us to track and examine changes in the healthcare provider marketplace, where providers are increasingly affiliating, acquiring, merging together to create new provider systems. We have an ability to both track that and in some cases do a full review of the potential market and cost impacts of those types of transactions. Different than antitrust, but I can talk a little bit more about that. I'm going to start with the investments we're making in community hospitals. The law included a $225 million one-time assessment on the health plans in Massachusetts, as well as some of the more well-resourced hospitals. And so this fund goes in a number of different directions throughout the law. It's a one-time assessment, but we collect it essentially over 4 years. And so the main chunk of that funding goes towards this Distressed Hospital Trust Fund, which the Health Policy Commission administers to make investments in community hospitals. The second largest chunk goes to prevention and wellness. The Department of Public Health administers this fund. Community grants based at reducing the rates of preventable health conditions. Third is electronic health records, and then finally, a little bit of money to help our operations at the Health Policy Commission. So we've been really working and focusing on this Community Hospital Investment Fund. I think one of the first things we did was we changed the name of it. It was originally the Distressed Hospital Trust Fund, and if there's one thing we found out from hospitals is they don't like to be called distressed. And so we changed it to the CHART program, and a great acronym, which is Community Hospital Acceleration, Revitalization, and Transformation, and it made it really an investment program. And I think one of the things we're really focused on building with this program is not just another grant program for community hospitals. We've had those in Massachusetts, and what's happened again and again is we write a check one year, we walk away, and we come back the next year and that hospital needs that same amount of money plus inflation. And nothing has ever changed in the trajectory of some of these hospitals over time. And so we're really serious about building a more a program that's an investment program that's really going to work with these hospitals to be able to understand where are their needs, where are their barriers to being able to create financial stability over time, and really be able to drive them towards transformation and to give them some of the capital that they need to be able to do care coordination, to take on alternative payment methodologies without necessarily having to go into a larger system if they don't want to. And so it's a $120 million program. You'll see the goals on the left-hand side. I won't go through them. Ultimately, you could probably boil those goals down to the triple aim, and you could probably boil those goals down to meeting the benchmark. That's ultimately what this is all about. And we see community hospitals as an important tool to help do that. We'll just report quickly, we did a first phase of funding of this community hospital investment program this past fall. We put $10 million out to bid. Really saw this as kind of a rapid deployment first phase. Let's get some money out the door. Let's start engaging with these hospitals. There's 30 eligible hospitals that can receive funds through this. No academic medical center is eligible to receive funds. No for-profit hospitals are eligible to receive funds. And finally, if your relative prices are above the statewide median, you are not eligible to receive funds. So 30 hospitals fall within all of those categories. We wanted to hear from hospitals what they were interested in this first phase, really made the program as flexible as possible, gave 3 different pathways, understanding community hospitals are in different places, pilots, infrastructure, and kind of just capacity building within the organizations. All the hospitals received money in this first phase. Really, a lot of them were focused on the first 2 parts of this, care coordination efforts, behavioral health integration, identifying high-risk patients and being able to build some programs around them. So we're pretty excited about our kind of initial phase of this program, but we're already starting to think about the second phase, and so the second phase is something we hope to roll out in probably the next 2 months. which would be something more like a $50 million opportunity for community hospitals to receive funding through this program. With that kind of a lot more money, I think we're going to be expecting a little bit more from our hospitals as well. There'll be a competitive pathway where we would imagine some deeper investments in some of these hospitals that are really poised to be able to do this transformation. So can think of grants in the range of $5 to $10 million over maybe perhaps 2 years, as well as trying to think creatively about the remaining pool of dollars, and are there kind of interesting ways to do grant programs. And I say this because I'm really interested in hearing if other people have ideas here, whether that's kind of pay for performance, kind of an all-in model, collaborative community hospital grant initiatives. If there's ideas out there where states have done this or other foundations or privates have done kind of a way to do a grant application process that has been a little bit more innovative, I think we're really interested in hearing about that, as opposed to just the one application, one pot of money being distributed to community hospitals. And then I think at the bottom, the last thing I would say is very focused on engaging with these hospitals as well. We see quality improvement, giving them some of the tools that they need to be able to succeed, giving them technical assistance, giving them supports as something that's an investment that we're willing to make in order to make this program be a successful one, as well as really building from day one evaluation. We have to be able to track whether this investment is really making a difference in these hospitals. It's a 4-year program, so we do have time to learn as we go along, and we do expect to learn. But in all things, the money runs out after the 4 years. We'd like to be able to make a case that this was investments worth making and perhaps continuing to make in the future. The second thing that I'll run through pretty quickly that we do at the Health Policy Commission is really monitoring our healthcare system, and here we have a couple of different functions. One is that we have an ability every year to hold annual healthcare cost trends hearings, and so we have the authority to compel witnesses to appear before us in a public setting and answer questions under oath around what their organizations are doing to advance the goals of the Commonwealth in achieving healthcare cost goals. So these are all CEOs of different healthcare organizations within Massachusetts testifying before our commission last year. This leads to an annual healthcare cost trends report that the commission conducts. And I'll just run through some of the interesting things that we did in this last year's report and kind of our inaugural report. One is we wanted to look and understand where Massachusetts ranks versus the rest of the country. And so this is a chart that really looks at the percentage of our economy that's going to healthcare. And as we can see, in the 2000s, we were pretty close to the US average, and during the 2000s, really separated ourselves from the rest of the country in the percentage of our economy going to healthcare. I would note that New York, the last number we have is in 2009, was 15.1% of their economy going to healthcare. It's gone down a little bit in the last 2 years, but that's actually more a reflection of our economy growing faster than the US, rather than anything necessarily happening different in healthcare in Massachusetts in the last couple of years. We have, on a per capita basis, are the most expensive state in the United States. And as we all know, the United States is pretty expensive internationally, so that's a problem. We have looked at this and adjusted these numbers we're a little bit of an older population. We have higher input costs. Again, that probably accounts for about 14% of that 36% difference between us and the US average. And so there are some characteristics about the Massachusetts healthcare system that lead it to be one of the most expensive in the country. One of those characteristics is that we receive a lot of care at our academic medical centers. So on the left-hand side is our discharges at academic medical centers versus the country. 40% of our discharges at those hospitals. The US average is 16%. On the right-hand side is all discharges at hospitals that are either major teaching hospitals or are part of a system with a major teaching hospital. That has grown from 60% of all discharges to 68% over the last decade. And we've had a number of recent mergers which will bring that number to 75% of all discharges occurring in these major systems. One of the other things we looked at was operating expenses of hospitals. And so, not kind of talking about their internal structures of how much it costs to deliver care in Massachusetts. And here we found a great variation among hospitals around a case mix adjusted discharge. Lowest at $6,000, the highest at $19,000 for the same type of discharge. Even separating out the outliers. Yep.
When you're looking at this, are you looking only at Massachusetts residents, or are you factoring in people who may travel into the academic medical centers from other states?
This accounts for those coming in from out of state. So these are hospital reported expenses.
One more question.
Yep.
Is this measured in costs or charges?
This is cost. So this is hospital reported their own costs, their internal structures. So different than prices that, this isn't a reflection of what they're charging the insurance company per se. But what I think the point here is that there's a great variation in our hospitals and how efficiently they're delivering care. And what we did is we lined this up against some quality metrics. And so we have this on two axes, and this is a little confusing, but really what the scattered chart shows is that there's no great correlation between spending more money per discharge and receiving better quality as far as a hospital concerned. Some are in that kind of higher efficiency quadrant of having a low expense and having really high quality. Others are not. And we ran this is excess readmission ratio, but ran it against a number of different quality metrics. And again, it holds up. So we see this as an opportunity, as a place where we can have conversations with hospitals around what are the types of techniques that could help make them more efficient and in turn hopefully reduce some of that pressure on receiving greater payments from the payers. Some of the other findings that we looked into was our waste in Massachusetts, and we did kind of a reanalysis of some national studies. Again, found pretty consistent results in Massachusetts. 20 to 40% of all healthcare expenditures are quote unquote wasteful. Those that don't provide requisite value, preventable readmissions, hospital-acquired infections, elective inductions, so on. And then the final analysis that we did was really around high-cost patients. And here we actually used our all-payer claims database for the first time and looked at our claims data and ran some algorithms that showed, again, like everywhere else, 5% of patients equal 50% of costs. But we were able to actually understand what are the clinical conditions that these patients are representing, what are leading them, what are good predictors that patients will be high cost in the future, where are there places where we can see persistence of patients from year to year in showing up in that high cost area. The last thing that I'll mention, and then I'll shut up because I've been monologuing for a little bit here, is this kind of new function in looking at market changes in Massachusetts and examining new hospital acquisitions and affiliations. And so it's really kind of a new structure. One of the things that we can do is really initiate this comprehensive cost and market impact review. And we have initiated and completed one such review of Partners Healthcare System, which is our largest healthcare system in Massachusetts, acquiring South Shore Hospital, which is still the largest independent community hospital in Massachusetts. And so we conducted a 6-month review of that transaction, resulting in a comprehensive public report detailing our findings about what we think the cost and market impacts of that transaction will be. While we're in our review, they cannot close the transaction. And so the transaction tolls until such time as the review is closed. Following our issuance of the final report, we can refer our report to the Attorney General's office for further action on behalf of consumers, either through antitrust or through consumer protection. In this case of our first report, we did refer it to the Attorney General. The transaction can't close until 30 days after we kind of do that referral. That 30 days expires on March 20th. So we're still in the tolling period while the Attorney General is reviewing that particular report. At March 20th, they would be able to close the transaction. So we don't have the authority to prevent or deny or block transactions, but really about bringing transparency on behalf of consumers and businesses about what these transactions may mean. And this just shows in our first 16 months, what are the types of transactions we're seeing in Massachusetts. I think probably no surprise to people who have been following this industry, a lot of physician activity, a lot of physician acquisitions and new affiliations. And then acute hospital acquisitions being number 2. Over 50% of the changes have been in those 2 categories. So I won't run through the kind of the challenges that we face, and happy to kind of talk about those in detail in our conversation. So having sped through that as quickly as possible, I'll stop there. And
So the tradition is I'm supposed to ask you lots of questions, and then I open up to the audience. But I'm actually going to only ask you one question, because this is all of our audiences at the Foundation events are great audiences, but this is a particularly good audience of a lot of leaders in our state who are thinking about this, doing something about it in associations, academia, and all. So I think their questions are going to be better than mine. But my question is sort of, how did this happen? You know, what were the power pushes and pulls? You know, when it was going on, and then how are people reacting to it now? I think some people in the hospital industry might have been have opinions about this, and some people in the employment. So how did all that work out?
I think there was a growing momentum that this was the next challenge that the legislature really needed to tackle. And I can't, I guess, give enough credit, and I come from the legislature, so I always like to do this, to the political leadership who saw this as a legacy issue for them in a lot of ways, around really being able to say, before our time is up, before this legislative session is up, let's do this comprehensive law and really set this path forward. It was a 350-page law. It was the biggest law we passed in the entire 2-year legislative session, bigger than the budget. It happened on the last day of session, of formal session. So, I mean, this was right up until that deadline when legislators like to work. There has always been a leadership and a political leadership that I think really drove this. I think one of the interesting dynamics that was occurring at the time is that it really was a debate that took about 2 to 3 years before that law got passed. And some of the different proposals that were on the table were more heavy-handed in the government area. Talk about returning to rate setting, talking about caps, talking about bans in restricting price relativity. There was a proposal on the table to tax providers that had prices that were above a certain threshold, and use those dollars and reinvest them back into community hospitals. And I think some of those proposals caused more anxiety than others. And the market at the time, and I would say that the healthcare providers and the hospitals at the time, really said, we can do this. We can do this on our own. We're changing, we're transforming, we're moving in a really dynamic way. Government doesn't need to overstep here. Government doesn't need to go to the rate setting route. And there was examples of providers following through on those promises and renegotiating contracts voluntarily with payers. I think one of the interesting things was, had there not been this political debate at the time, would providers have taken those voluntary steps? And so ultimately where the law landed was that the legislature and the political leaders walked right up to the edge of kind of full-on regulation, and then ultimately took a step back. And they said, we're going to continue to see if this market can fix itself and can work. However, we're not going to walk away completely. And really the creation of the Health Policy Commission is an attempt to institutionalize in one place that pressure, that constant pressure and accountability to continue to move, to continue to change, and to continue to use our bully pulpit to help steer the market in a way that we think is going to be most effective.
Yes. You should introduce yourself.
We've been debating for many years. Bob Wojtulis, CEO of Health Plus here in New York. We've been debating for many years since Richard Fuchs' book, the public utility model as a way to regulate healthcare. Do you believe that what you've set up in Massachusetts is moving toward that model?
I think there's, certainly some structures are being built as far as the ability to collect more information. One of the interesting things that exist within this law is really having a connection with physician organizations for the first time. The state has always kind of had good licensing and regulations around hospitals. Physician organizations are being brought in a new way. But I think it's kind of the big experiment here. I think the legislature, the law could go a couple of different paths depending on if we're successful or not. If we're not successful and the industry continues to grow at a faster pace, I have no doubt that there will be proposals to give us or another agency more power to go further down the regulatory route. If it does appear that the market can do some of these things and achieve those goals, probably a different reaction. And we're seeing that already in, where our governor right now is leaving public sector, and there's another number of gubernatorial candidates who all kind of have probably different views on that spectrum. So it's not clear where it goes from here, but I think to be able to achieve these goals, you either need two things. You need a market that's working and that can effectively set affordable prices and drive people to the right place at the right time, or you need consumers that are demanding that out of that system, or you're going to need a stronger government hand. And I think we're still working to see if we can make the market work, but certainly the question will remain, what if it doesn't?
Paul Maslach, Health Plan Association. Can you spend a minute or two and describe what's described as a global cap and how you set benchmarks for different sectors? You said it's 3.6%, but some sectors are given more leeway, perhaps others. So how is that benchmark setting done, number one? And then number two, on the measurement side of it, is the measurement of the sector to see whether they hit the benchmark or exceeded or below it, number one. And then number two, even within the sector, does the ultimate, power to go back and get the compliance plan address the sector or individual players or hospitals or physician groups within the sector? How does that work?
I just add one thing.
Yeah.
How about the timeliness of the measures?
Yeah. So this is one of the trickier parts of this whole law, no doubt, and the central part of it. So let me start there and then get to your questions. So the first year that we're measuring against this benchmark is growth between 2012 and 2013. Because of the data lag issues, we're not going to know that number until probably September of this year. And so we're 10 months after the fact being able to retroactively judge whether the state as a whole has met the benchmark or not met the benchmark. This year will be the first year that we do this calculation and see if we hit 3.6%, which was that number. Within that, there will be identification of individual payers, individual hospitals and provider systems that have exceeded that benchmark growth. And so if we as a state, exceed the growth, the Health Policy Commission has the authority to require individual providers, systems, or health plans to basically come under strict monitoring and to submit performance and compliance plans in order to increase their efficiency. We do have some discretion. So the commission has an ability to look at a provider system and understand, well, why were you growing faster? Are there things that were beyond your control that we should consider in demanding that you require this performance improvement plan with us or not? Are there investments that you've been making that we think are credible as far as leading to future efficiencies? Have you been trending in the right direction? Now, we may dismiss some of those considerations and ultimately say you're above, we're forcing you to take some drastic steps, or we may say you're moving in the right direction, and despite the fact that we came in at 3.8%, we still see some positive trends as to where we're going, and we're going to continue to let the market work. So there is some discretion there, but it is, and I think the analytics that we as a commission would run would be both kind of provider and system oriented, but also probably around service lines, around kind of sector-wide. Is it community hospitals? Is it academic medical centers? Is it community health centers? I mean, we'll try to probably splice that apart in 12 different ways to really understand what's driving it or not driving it. But ultimately, the accountability is on the providers and payers themselves.
How do you set that benchmark? You said behavioral health might be above 3.6, something else has got to be below. Who and when is that benchmarking set?
So ultimately, it's still a private negotiation between the health plans and the providers. And so the health plans and the providers are at the table right now negotiating their contracts for the next 3 years. The health plans have told us that they are using this as a real goal. And so for providers who come in and they may require increases in certain parts of their price schedule, it need not be that everything has to grow at the same amount. But it still requires a private negotiation between the health plans and the providers.
I'll go back.
Kathy Sherrill, the Grand New York Hospital Association. So when you look at, similar to what Paul was asking, he was asking sort of by service category, but also by different type of payer. Are you just treating things sort of as they come? Are you making any adjustments on the Medicare side for cuts that they've made to pay for the ACA? Because Medicare trends have been flat. So does that allow for more room on the private sector?
The benchmark as it's set now does not adjust for kind of those types of fluctuations. I think, again, that's a place where there is that discretion left to the commission. And so certainly if if it's a health plan that we're looking at, as far as a health plan has somehow contributed to excessive growth, I think part of that would be through their contracts. They've been giving out kind of richer contracts as a health plan that have led to us busting through the health plan growth. But again, there could be an examination to say, where have you been kind of handing out the higher contracts? Has it been to providers who have been traditionally low paid? Are you cost shifting from Affordable Care Act or from the commercial side or from the public side? So it's on some of these things, it's not quite as black and white. And I would say where we sit right now in Massachusetts and not having done the judgment part of this, it's a big uncertainty for the industry. And I would absolutely acknowledge that they are asking me all of these same questions and asking us as kind of the Commonwealth, what is the target that I need to hit so I know that I can hit it? Some of that is still kind of in the process of being figured out as we roll this out.
John in the back.
John Wilson, you said you're certifying ACOs. Say a little bit more about your activities in ACOs. How many are there? Are you restricting ACOs as well?
Great, yeah. So one of the two areas where we're working to help steer some of the system transformation that's already happening is one is a patient-centered medical home certification program, and then I think more interestingly, an accountable care organization certification program. The ACO certification program, it's a voluntary certification program, but we do have, the law does allow for this idea that certified ACOs would get preferential contracting for public business. So public business through our state employee, health insurance system, preferred contracting through our state Medicaid program. So there is a little bit of a carrot there for providers who are thinking about going through the certification process. We haven't come out with those standards yet. We've been a little bit focused in this first year on the PCMH side because it's frankly a little bit easier on the PCMH side. I mean, patient-centered medical homes have standards that are kind of nationally accepted. And when you're talking about a PCMH, you're talking about primary care practice, physician practice more than not. The ACO, we have the twin challenge of one, what is the thing? What is an ACO? And we could probably go around this room and every single person in this room would have a different answer to that. And then what do we expect them to do? What are the standards that we're going to hold them to in being so-called certified by the Commonwealth as far as coordinating care across settings, accepting downside risk-based payments, being able to transfer information electronically? And so that's something that we're working on, but it's, there's no great models that exist kind of outside of us. Pioneer is one, but this is different. I mean, this would be kind of a commercial ACO as well. So providers are particularly interested in us moving this forward, but certainly something that we want to do well and do right as we're rolling that out.
Chris?
Hi, Chris Kohler from the Millback Fund. Two follow-ups to these last two questions. First, on the measurement, as you've gotten down below a global measure, have you thought anything about population-based measures of costs, attributing patients to provider groups, and have you crossed that threshold yet? And then on the ACO question, how is the work that you're describing linked to your SIM work as a test state in one of the 6 states that got the money first?
So I would say on the first part, definitely still a thought, but something that we're really interested in doing. We are running a lot of this analytics through this our all-payer claims database, which is a really incredible tool, but is a tool that is very much still in development. And so doing different types of attribution to different providers, being able to understand kind of on a patient level, having a single patient identifier so that you can be able to track where those patients are going across different payers as something that is still kind of in development. We need to kind of work through some of those issues, which I guess one editorial comment just on that generally, which is I kind of blew through the key challenges thing. Having good data is so critical to do any of this work, and I think we're kind of blessed to be in an advanced state in having this available to us, but there's still so many areas where we're wanting to be able to go and drill down to that next level. And really, I think the timeliness of the data is just a challenge for everyone who works in healthcare. I mean, we're making judgment calls about the next 5 years, and we're looking at data that's 24 months old, and so that's a really hard thing for us. To bring it back to your second question, which was really around our SIM grant, so we received a $40 million SIM grant from the federal government. A number of the things that we're working on there are kind of in support of our ACO program, in support of the different types of activities that I talked about. Our NYSHealth program has just rolled out kind of a new primary care payment reform model. This has a new alternative payment model for our Medicaid program. That's literally just got launched a few weeks ago. And some of the SIM grant is working to advance that. They're interested in working with, the Medicaid program is interested in working with us around our ACO certification and making that kind of the next phase of payment reform in the Medicaid program. One of the things that the law did, which I didn't mention, is that it really has this idea of the public programs being kind of the driver of some of these changes, and so there's strict requirements that Medicaid has to be at 25, 50, 75% alternative payment methodologies by certain target years, that ACOs have to be at certain target years for the Medicaid program, and also for our state employee insurance program as well. So there's that concept of kind of the state driving it. But one of the interesting things the SIM is also supporting us in is actually allowing a portal for providers to be able to access some of that all-payer claims data too. One of the things that they've really told us is that if you're going to put us in charge of managing risk for an entire population, we'd really like to know who our population is and where they're receiving care across a number of different settings. And so one of the things that we're working on to support kind of the ACO work is being able to help providers get that type of data.
So a number of your examples have been on hospital costs, and it sounds certainly as though you think that's the culprit out there, but what as part of this is being done, didn't pick this seat in particular, but to evaluate the payers and their inefficiencies and physicians.
Yeah.
I mean, both obviously contribute to the cost. It isn't all on the hospital side. How are you collecting that data and focusing your initiatives in those two sides of the coin?
Yeah, no, absolutely. I think I get that question sometimes from our hospital associations, like, why are you picking on us? And I think in some cases, for some of these analysis, frankly, the data is the best for the hospitals, and that's where we have it. We know with our hospitals and our physicians, it's about 70% of our total healthcare spending, so we do focus there a little bit. And even in our cost trends analysis, when we looked and said, why are we more expensive than other states? What we found is much more hospital use than other states, much more outpatient hospital use than other states, and more long-term care. And so in thinking about where there are opportunities, we do look at those specific areas. But I would say one of the things that I mentioned before where we don't have great information, but do know can be very significant drivers of both kind of cost and market impacts is our big physician organizations. Where they are set up and where they're directing their patients and where they're referring patients can have just as much of an impact on cost as kind of the acute care hospital sitting in the middle of that. And we've seen physician organizations in Massachusetts that shift affiliations from one hospital to another and shift a massive amount of cost and patients with those affiliations. So understanding the physician market is absolutely something that we're focused on and starting to collect more information on. For the health insurance side of this, our Health Policy Commission has both, in kind of measuring against the benchmark, we do look at payers and as well as providers. We have medical loss ratio standards that we have put in place in Massachusetts, an 88% MLR, and that's, I think, an important tool for us to know that as we're driving some efficiencies in the provider side, that those are flowing back out to consumers and not being stuck in our health insurance companies. We did do an examination of how much their retention has been over the last 2 years and saw a great increase in the retention in the insurance companies in Massachusetts. A particular concern to us in these last few years. I would say our division of insurance works most directly with the insurance companies, and our governor has not been shy about demanding that the Division of Insurance use its rate review process to hold insurers to a tight standard as far as what the premium growth has been over time. Want to be balanced in all of these examinations, and as the benchmark also includes the net cost of private health insurance, it's not about kind of picking on one sector here. It has to be that comprehensive look and thinking about how these pieces move together. Or else, again, you're going to be missing kind of the forest from the trees.
Scott Morgantown resident. Again, kind of looking at, you talk a lot about hospitals. To what extent are your transformation efforts looking at moving patients out of the hospitals and not just making the hospitals themselves more efficient?
Yeah, so I think two things that we're focused on there. One is on our patient-centered medical home initiative. So that's trying to kind of keep people within the primary care setting, keep them preventable readmissions. Our grant program is hospital focused. Our $120 million is for community hospitals. But I think what we found in the first phase, which we're really kind of excited about, frankly, is that the hospitals, when they came to us with their grant applications, had marshaled all of their community providers and said, let's do this together. And so it wasn't just the hospital alone on the application, it was the hospital plus the practice, plus the post-acute setting, plus a school nurse, plus a community health center who said, we're as a community gonna work on, identifying high-risk patients and keeping them out of the ER. And so while the money kind of flows into that hospital, I think we do see a disbursement from that in being able to hopefully kind of bolster up those community care. But we're, in Massachusetts and everywhere, we're still kind of stuck in between two different systems. We have a fee-for-service system that pays pretty much half, about 60% of what our providers are receiving kind of on a statewide basis. And we have a lot of alternative payment methodologies. We're one of the leading states as far as adopting that. But our providers are stuck in the middle. And for a hospital, to make investments and to make decisions about moving people out of their beds and moving people out of their emergency room and preventing people from showing up in the emergency room, you're spending money to lose money, essentially, for some of these hospitals. And that puts them in a really tough place. And so the payment system has to be part of this conversation. And unless that payment system can accelerate it, and create the right incentives to support the investments that we're trying to make, it's always going to be probably like spending money and losing money at the same time. If we're working at cross purposes from the payment incentives that the payers are putting out, then I don't know that we're going to be successful in the long term in really being able to transform care, because again, that incentive will always be there to kind of keep the revenue, and that's not a bad thing. It's just kind of the way that the economics work. Yeah.
Hi, Tricia McGinnis with the Center for Healthcare Strategies. I'm wondering if you could talk a little bit more specifically about the changes that you're seeing in health plans implement, and which of the levers that you have at the commission do you think are really driving those changes that you think other states should be looking at?
So on the health plan side, we're, and we've spent a little bit of time looking at this in the last year. We're in a little bit of, and I kind of alluded to it in this last question, we're a little bit of a tension area right now. The health plans have been really promoting new types of alternative payment methodologies. Our Blue Cross Blue Shield is our #1 payer in Massachusetts, accounts for about 60% of the market, a dominant payer. They have been actively promoting what they call an alternative quality contract. It's a global budget. It sets targets. You can, has quality bonuses attached to it, but really is about kind of reducing trend over time, and has been really successful in promoting and getting providers to buy into this global budget-based system. Other health plans have done other types of kind of alternative payment methodologies, some global cap, some bundled, but all of these types of payments are on the HMO side of our business. And so while they're taking up an increasing portion of our HMO side of our business, what we're seeing in Massachusetts in our marketplace is that businesses are choosing PPO. And they're moving towards more consumer-driven health plans, they're moving towards high deductible health plans, they're moving towards that side of the market. And so while we've seen payers really try to advance these new type of payment methodologies, and actually as a percentage of HMO have really increased it, as a percentage of kind of total patients covered has actually gone down in the last 2 years because of that shift towards the PPO side. And so payers, and we've been pushing the payers to think about expanding those types of alternative payment methodologies to the PPO side of their book of business. Blue Cross Blue Shield still says that's probably a year or two away. But there are models, Pioneer is kind of a PPO modeled attribution type of way of doing an alternative payment methodology. Not the best or the only way, but the market right now is kind of moving in 2 different directions. And if we're going to be effective in really taking hold of the alternative payment methodology movement, we're going to have to kind of align it across these different markets and across PPO. I think the other thing that the payers have done in Massachusetts, which has been effective, is some of these new tiered and limited network products. As I mentioned earlier, the state law required that they design a limited network or tiered network product that had a 15% reduction off of their kind of general network product. And the plans kind of told us at the time, we've tried these before, no one wants them, everyone wants the full general network product. And what we've seen is they're actually the fastest growing products in Massachusetts. There is a demand for businesses to have alternatives as opposed to increasing deductibles or getting rid of their health plan altogether to be able to do a tiered or limited network type product. And we've also seen some impact on the tiering side, especially where providers who are on the margins are willing to come back and renegotiate and say, I don't want to be in tier 3, I need to be in tier 2. So how can I get there? And that has an impact even kind of beyond that specific product type. And one of the things that we've been pressing the payers and that we launched this last year to do is to be able to provide really transparent price information to consumers. So we just actually launched this last year, and it was a requirement of this law, and something that we're pushing the payers to continue to advance is kind of transparent tools for members to be able to go online and be able to understand what the price of a different type of service would be at a number of different providers. Not some average charge, but the actual price that I, David Seltz, would pay with my copay and deductible system, with my health plan. So it's much more actionable than kind of the random kind of maybe it's in this $1,000 range of tools that have existed before. And we see that if we're going to get consumers involved and being able to make some of these decisions and kind of market-based decisions, they have to have the tools to be able to do that. Actionable price information and quality information is one way to do that. And the payers have been, kind of interested in moving that forward.
Joe?
Joe Baker from the Medicare Rights Center. So 2 kind of somewhat unrelated questions, but I want to follow up on what you just said. So it seems that, we talk about hospitals, health plans, et cetera, but it seems that given the South Shore situation, and I assume your recommendation to the AG's office was to, look at that in a managing trust a thorough review. It seems like a linchpin of the market working in Massachusetts is keeping community health hospitals healthy and as strong competition to academic medical centers. Yet the rush for consolidation and physician acquisition is upon us and happening. So I don't want to, I almost want to ask you, don't you think that's doomed unless you really pump a lot of money, more than what you've got, into community hospitals? And Blue Cross Blue Shield has 60% of the market, so why shouldn't some hospital system have 60% of the market and go toe to toe, right? But then the other question is the poor little consumers. So they've got good price information, which I give you a lot of credit for because that's rare. But what about the quality information? And do we really think consumers want limited networks? They're crying for limited networks? No, they want a cheaper health insurance policy, or they don't want to pay that whopping deductible. So, what are you doing to really gauge what consumers actually want out of the system? Is there a role for the commission to say, you know what, community hospital X is really cheap and got great quality, go there. Get your hip replaced there, don't go to big old academic in, Boston. So, a lot of stuff going on there.
Yeah. So let me take the market structure piece of this first. The fact that we even have this authority to stop transactions from happening and review them on behalf of the public, and that there's a report that comes out that transparently examines what those impacts can be, is kind of, in my mind, a huge step forward on behalf of consumers. I think, the past ways that states have looked at this has been through antitrust. And what happens in antitrust is that there's, 3 outcomes usually in an investigation. The investigation stops, and no one ever hears what happened or what the findings were. There's a settlement, and again, no one ever finds what the extreme concerns were. Or there's a complaint brought to court, and that's the rarest of the rare, especially kind of given long history of DOJ and FTC action there. Although there was a recent case in Idaho of a physician merger that the FTC actually won on. So we don't have the power to stop, but nonetheless, I'm optimistic about the power that sunlight and transparency can bring to this issue. And what we've seen is that already providers who are thinking about partnering, small p partners, are wondering what we would think about it, and what are the things that, as a commission, that we're going to say about this when we issue our final report. And that's having an impact on how they consider who they're going with. And so we care about TME, we care about relative price, we care about the quality performance, and we care about access. And we care about access in terms of what is their percentage service mix for behavioral health. What is their payer mix for Medicaid? These are the types of metrics that we're bringing kind of into the spotlight for the first time. Will that be enough, and will that work? I don't know. But I do think that there's a space for different types of affiliations between providers. We have, in Massachusetts, another type of provider who is contracting together for the purposes of risk contracts, but is not all corporately owned by the same kind of parent company. And so there's different ways of doing this. We have smaller physician organizations that have been really successful on Pioneer ACO and Medicare Shared Savings. So it's not that they can't do it, but I see it, we're tracking it, that pressure to be, who is going to be my system for the next 20 years. Every independent community hospital is having those conversations right now, and they're thinking about it. It's, as you said, I think it is important for how our system shakes out, and we're really jumping in the middle of something that is, turbulent around us in a lot of ways. The second thing which you mentioned was really around how do we bring consumers into this conversation, and that's something that we talk a lot about. We have a consumer advocate as one of our board members, and kind of on the transparency thing, price alone, what we found in a lot of cases is that in some cases providers look at that and they say, well, if it's higher priced, that must mean it's better, right? And so it actually can have a bad impact as far as saying, well, I'm only paying the first $500 of this service, and it's a $20,000 surgery. So if it's a $40,000 or $20,000 surgery, if I'm paying $500, what does it really matter? This place must be better. And so, linking up quality information has to be, it's about that value judgment. And the quality side, as we all know in healthcare, is the hardest part, because it's how do you define value in healthcare? Is it the process stuff? Is it outcomes? Is it, what's quality for a hip and knee versus quality for schizophrenia or depression? It's such a hard thing to define. But one of the things, I think there are places where you can define it, like on a hip and knee, and you can talk about, acquired infections and kind of recovery times, and you can see across Massachusetts, every hospital does pretty well. It's really high quality. And yet we're seeing a huge differential in the prices paid for those types of services. And so one of the things that we're interested in looking at in Massachusetts is the CalPERS experience of looking at hips and knees and doing kind of reference pricing in their state employee program around, kind of setting, this is the number. If you want to pay more and go someplace else, you can pay more. But otherwise, we'll cover it if it's at these hospitals with the lower prices. What it ended up actually doing was not necessarily consumer activity, that they were paying a bunch more, consumers were having to pay a bunch more. Hospitals brought down their prices. Right. That's how they got the savings out of the system, because no hospital wanted to be excluded from this. And so I think kind of separate from the hips and knees, but to the consumer side of this, we're thinking about this year a consumer campaign around some of these issues, around how to make value choices in healthcare. Consumer engagement, and I won't go too far down this tangent. Consumer engagement means a lot of things when it comes to healthcare. It's around how you pick your health plan. It's around how you pick your provider. And in some cases, on the patient side, it's how you engage with your physician or your nurse practitioner around the types of services you receive. Do you need surgery, or will physical therapy do? And there needs to be some education that comes around with all of this. We did, when we first passed healthcare reform in 2006, we did a huge ad campaign, sign up, like ACA now. We had the Red Sox, endorsing our connector, go sign up for healthcare. I don't know if that works when you're talking about accountable care organizations. So it needs to be a different type of education, but nonetheless, unless you're having some of those value conversations, and I think, honestly, I would say businesses are another part of this, because they, especially the self-insured businesses, see some of those costs most dramatically and directly. And if you can get them involved in this conversation as well with consumers, you can really hopefully be able to drive some change. So we're interested in getting the consumers involved.
I want to try the back for just a little bit. John.
John Lane, hospital trustee. You mentioned clinical integration in one of your slides. How do you see it playing a role in the dealing with the cost and quality issues for community hospitals?
I'm sorry, what was the first part again?
Clinical integration that's on your slide. What do
Yeah.
you see that as a role for the future for community hospitals? Is that important? Doesn't work? Antitrust?
I do see it as an important part of this. I think there's places where within hospital systems, within community hospitals, not all of our community hospitals, even in our grant program, are independent. Some of them are part of bigger systems and happen to kind of fall within that category. And so, in thinking of ways to become more efficient and having a team-based approach to healthcare and getting rid of some of the variation that exists across different, practice sites, and being able to help community hospitals do what they do and do it well is something where I think they can continue to learn from some of our more well-off hospitals. And it doesn't need to be I think we're thinking about our community hospital program as both learning from each other, but also learning from best practices from other places as well. And there are ways that clinical integration, I think, can help drive some of those alignments in thinking about what is the right type of care that we want to keep in the community and that can most appropriately be served there. And there's some care that does need to go to that tertiary center, that does have that more complex care, and how can we drive some of those changes in an efficient way.
What about technology, innovation? I guess the current example would be the new hepatitis C drug. It's driving a tremendous amount of cost into the system. How do you account for that in your global cap?
So certainly pharmaceutical companies, medical device companies, large part of our bio-life sciences center in Massachusetts is around kind of the innovation side of this. There's no exemption for those types of things kind of from the benchmark, but I guess I would put it in the same category as they're within that discretion. And to say, again, are there things outside of the provider's control that have led to this cost growth? And so that would be something that we would always want to examine. You know, I think there's a tension and an experiment here, which is around kind of the innovation side of this and not wanting to stifle innovation in Massachusetts in achieving, you know, the goals that we've set out here. Healthcare is the #1 employer in Massachusetts, right? It's $68 billion a year. I mean, this is a huge business and competitive source for what we do. You know, we sell this to the world in healthcare. You know, Mass General does, and some of our other great institutions. We can't, you know, we need to balance our goals against, you know, what is a strength for us. And I think, you know, do we hit the right balance? Do we not? We'll find out. And that's why I think even in our cost trends reporting and being understanded, for me, you know, especially in probably the first year, it's not going to be about whether we hit the benchmark or not, but why. And I think there could be reasons why we could not, you know, we could get under that 3.6%, but when you kind of get under the hood, you could say, that's real, you know, there's some concerning things here. What we found was that actually providers or payers just decided to cut off a bunch of stuff that was expensive, and then, but we know will lead to costs further down the road. And the flip is true, you know, that there could be cases where we see costs that were exceeded that 3.6%, but can look under the hood and say, those are investments that we think will pay off in the long term. And so, you know, again, you need to have that goal, you need to have that benchmark, that rallying cry, but it can't be something that's so static and extreme that it can't allow for some of that fluctuation.
Go back to the back again, Paul.
Yeah, New York State's executive budget this year has a proposal that essentially would enable for-profit companies to enter the hospital. What is the situation with for-profit hospitals in Massachusetts, and how do you see them playing into this cost and quality thing?
Massachusetts has traditionally been a non-for-profit based hospital system. We had a recent kind of major entry into our market, Steward Healthcare, which is based out of St. Louis. They're kind of a parent private equity investment group that purchased up a number of community hospitals. We have a foothold from Tenant, which is another kind of big national hospital system that just purchased a couple of our hospitals. I think Steward, there are continuing questions around their financial performance, and they've lost money in the last couple of years, and they have turned things around, but there's a question of...
You mean lost money in Massachusetts, or?
Lost money, just the hospitals in Massachusetts, as they've really took over some struggling community hospitals and made some investments in them, took on some of the debts and burdens, you know, I'm not speaking from any inside knowledge, but the buzz has always been, well, when are they going to sell, right? Are they going to sell these hospitals to another for-profit and try to make a profit and walk away? And the CEO, to his credit, has said that's not their plan. They want to stay. They believe in Massachusetts. But the culture has always been one that's a little bit more for-profit based than for-profit based, and entry into the market on the provider side. Again, I'm not speaking from any expertise, but observing seems pretty difficult in Massachusetts, and so I think we're working in a non-for-profit area, and I don't know that there would be how you would think about kind of drawing in more that and what that would mean. That's not, I guess, a direct answer, but.
Dennis?
Dennis Whalen, Healthcare Association. So it's a little bit about some of the last couple of questions on this issue, and it's two-part. One, do you see any impact or change for you as landscape may shift more to systems that are payers as well as providers, or all parts of the continuum of care and their system. Is that a good thing or a bad thing? And secondly, does the commission have the authority to decide we should do reference pricing, or like Maryland, we should go for an all-payer system that includes Medicare? Or is that more bully pulpit, or are the recommendations to the legislature?
So we are seeing that shift as well towards not only kind of provider systems, but provider systems that are interested in pulling on health insurance plans with them as well. Again, Partners Healthcare, which is our biggest system, purchased one of our health insurance plans about 2 years ago. And so have seen that. Steward Healthcare, which was the for-profit I was just mentioning, has really been interested in selling kind of direct insurance to businesses and consumers. Whether that they need to then license as an insurance company or not has been a source of some ongoing debate. But I think compared to other states, that hasn't been our tradition, as compared to some that really have these payer-provider systems that have kind of evolved together. And so I don't know that I have strong opinions on it one way or the other. Kind of on a theoretical sense, I can see that you can really start to align incentives in a way that could really help to drive change. I would worry about some systems only contracting with the payer that they are and kind of setting up segregated models for consumers where if they want to kind of be able to access these hospitals, they have to go and get this one health insurance plan, and there's not kind of a competition-based way.
It's a small step from some narrow methods that I've seen to that.
Yeah. So, I think one of the things that underlies the debate that we had in Massachusetts and kind of ACO is what are these things 5 years from now? Are they insurance companies? Are they taking on full risk and managing every part of the population? What is the role for the insurance company after that? And some of these questions, are kind of fundamental for the next 5 years, and were not answered as part of this legislation. And we're sitting in the middle, trying to examine and understand it, and hopefully help steer it in the way that we see that it could be most effective. But there's no clear answers on where some of these things. One of the things, just as an example, one of the things that as a commission we're responsible for doing is doing external reviews of patients who are denied care in an ACO. So an external review process is something that's always been a health plan process, where they could deny, appeal a claim. What does that mean in a provider setting if a physician says, no, I'm not going to provide you that service, and then they appeal to us? We're getting into kind of some new territory in some of those things. To answer your second point real quick, so we have a kind of a mix of our own responsibilities where we do have some power and authority to create programs, and then we have our bully pulpit, and we have our ability to kind of recommend changes for other state government agencies, and so cannot impose them on Medicaid, can't impose them on our state employee union, but have the ability to work with them. And then as well as recommendations to the state legislature and to the market in general.
Mitch, I'm going to let you take the last question, and then I'm sure David will stay around if you have individual questions after.
Mitch Rubin from Emerald Health. You referred to the highest utilizers, the highest cost utilizers, top 5%, 50% of the equation. Being that there have been, in the last 5 or 10 years, a flurry of very good articles, very good studies, and very good attempts, and arguably not so successful, is your commission, does it have reason to be optimistic that that side of the equation can be dented?
I think just generally my natural demeanor is to be optimistic. I think we're we're at the outside of this thing. I think if it was a year in and I was already pessimistic, I'd probably need to get a new job. But I think to this point, we've been talking about kind of the costliest patients for a long time as a system. This isn't something new. But one of the things that we think about with our kind of our research arm of the work that we do is how do we drive that back into policy? So how do we take what we're learning here on saying, okay, here are the costliest patients, and among them we see, okay, there's these acute, leukemia, cancer, got hit by a bus type of things, and then there's this chronic stuff. Okay, here are the different types of conditions. We can now map that against where they are in their communities, what types of providers they're going to. And so as we think about our PCMH program, or our accountable care certification program, can start to think about, all right, here's the types of interventions that we're going to be requiring providers or encouraging providers, or our investment program investing in providers to be able to do these specific types of activities that we think can actually make a difference on driving some effective change within these costliest patients. We found, for example, that we looked at comorbidities of chronic disease and behavioral health. If you had both of those conditions, no surprise, your costs were much more than the individual sum of both of those conditions. So bringing behavioral health and integrating behavioral health into the clinical setting, into the primary care practice is something we're really interested in as well. The division between that has been something that has plagued our system and bogged down our system for a long time. But I think from my perspective, we're not here to kind of put out reports and to kind of put out like, oh, isn't this interesting? Our goal and our effort is to drive this back into policy, drive it back into system transformation, and work with the market and give them the tools to be able to do it. And so yes, I'm optimistic, and sometimes it takes a catalyst to bring together these different organizations. And I think I'll just end by saying one of the questions was, how do people feel about it now, 16 months in? And the coalition that really was behind this bill, was behind 2006, is still very much together. They understand that they are all invested in the success of this. And while there's a lot of anxiety in healthcare generally, and that's caused in part by some of the things we're doing, and part of it's just a national anxiety around healthcare right now, I continue to be encouraged by the fact that the leaders are still walking to the table and saying, how can we help? How can we do this together? Not running to the corners, as I said before, and playing defense.
David, I want to thank you. You win the award for the most questions. I think everybody in the audience had at least 2 questions they wanted to ask you. And I think that's because you're doing really important work, and I think a lot of us are watching. And I just came back from a national conference, and people are watching, I think, nationally. So I'm really pleased that you took the time to share with this. And we have a lot going on in New York, despite my teasing in the start. And I'm sure we'll all reflect for a while about what we learned today. Thank you very much.
Thank you.